We start out with the regular assessment, just assessing like the shoulders, the muscle, posture, and also we're gonna do a manual muscle test. So the first one, do you guys remember all the rotator cuff muscles?
No, let's read it.
All right, so sit. So S for supraspinatus. So that muscle is responsible for flexion and abduction. So if you face me, so what happened? Flex and abduct. So this is we call it scaption or like a Y pattern. So we'll have him come up and resist my motion. Good. So that's called the full can, or you do the empty can, which is also a special test to assess the supraspinatus muscle. And once again, resist my motion. And if he had any weakness, then that would be indicative of supraspinatus tear or even any of the other rotator cuff muscles, but usually supraspinatus. You also have the infraspinatus. You guys remember what motion that does?
Is it
External rotation. Yes.
external?
So you have him come out like this, and you have him bring out, external rotate, going into my palms. And that's assessing the infraspinatus muscle. And also the teres minor next. And I remember teres because it has an ER in it. So external rotation of the teres. Once again. That's just a little tip. Next is what's the other muscle? Subscapularis. Yep. That one does internal rotation. So I cross my hands just to give you a little bit more balance. This way. And just gives you more mechanical advantage. So
if that was torn, you'd be able to move his shoulder forward too, right?
yes. And another way of assessing infraspinatus is what they showed us. It's called the belly tap. So his face.
You're fine.
I guess you do this one. Yeah. So you have him press on his belly, and he should be able to move it over his torso. But if it's not aligned, then you can see that there'll be infraspinatus weakness or tearing. With this one, you want to be able to assess internal rotation of his shoulder coming in. And the other one that we were taught was the aptly scratch. So you do it this way. Oh, sorry. So with this one, you just want to measure where his thumbs are at, come out. Then you do the other one with your left hand. Go ahead. And you just want to look for any type of differences. So you just look for symmetry. Then that's one motion, and then the other one is behind the back. Same thing. Now opposite hand. And see, so it's pretty even. And
for these, you'll expect some differences on your with your dominant hand.
right.
So it'll be pretty obvious.
That'll be obvious.
Yeah.
And the other one is this one, and did you do this one?
They did that one.
Then over now.
So which one? So you.
Yep. There you go. That one.
Do you ever do both at the same time? Like
Yeah.
this?
Now another one is just to make a quick assessment. Is just do it at the same time. Right here. Now do the opposite. And pretty similar. And the other one is the lift-off test. That's also assessing the infraspinatus. So you put your hands on your back. And you ask the patient to press off against me. And just looking for the same indication of infraspinatus weakness or tear. Subscapularis, sorry. Yeah. Any questions?
Do you do all three of those?
No, usually I just do lift-off
I
tests.
do these lift-off tests, like it's.
And then I
it's
assess
easy.
internal rotation, yeah. But just in case.
Whatever makes you feel most comfortable with, really, is kind of how you go.
Okay. Next we can do anterior instability, so you can lie down. Let's see. Is this okay? Actually, yeah, this one.
You're fine.
This one? Okay. Anterior instability or apprehension tests. So I usually I balance the patient's elbow with my thigh, and what you're gonna cause is just external rotation of the shoulder. That will elicit instability or pain on the anterior aspect of the shoulder.
So this is also for rotator cuff.
More instability, anterior instability.
So if someone has dislocated their shoulder or subluxed, it would pop down, pop back in.
Subluxation, dislocation.
Is this the crank or the apprehension test?
It's the apprehension test. I think it has it backwards on the sheet, maybe. This is the apprehension. And then joint relocation is Just use your hand this time, and you can use downward pressure to cause extensive range of motion. So you're gonna improve the patient's range of motion with this one.
Yeah.
So you press
so
down.
looking for, like this in general.
I don't know if you can tell, but his range of motion is slightly improved.
So like.
Then we have the surprise test, where we lift off, and that should elicit more pain. There's no pain. Thank you, sir. And then you get to sit up.
That's good. Like this
And then next is the load and shift test. So this one, you're gonna stabilize. You use your right hand to stabilize the scapula, the clavicle. Then you're gonna grab the humerus, proximal humerus. You're gonna put an axial load into the glenoid fossa, into like the joint. And then you're gonna do anterior and posterior glides. And this one's the same thing. You're looking for any type of labrum tear.
So you're pushing with that hand on
Pushing.
his shoulder.
I'm stabilizing this one.
Oh, you're just stabilizing.
Yeah.
You're gonna grab
Grabbing the humerus,
the humeral head basically.
and I'm pushing into the labrum, and I'm shifting it
Okay.
anterior and posterior. And this one we do pretty often.
Yeah, this one's a good
one.
indicator of instability.
And he's not being like, it's not like a gentle
No, it's
touch.
actually
He's
good.
got a good hold of.
You really have to grab, and or if you don't grab too hard, firm enough, you're just gonna move skin,
Yeah.
and it just doesn't really actually move in the bone itself.
Is it harder like if I were a 300-pound lineman or
Yeah,
something? Yeah.
Another one that we can use for, this is usually pretty sensitive and positive, or false positive, is the O'Brien's test. You guys remember that one? O'Brien, yeah. So it's for a slap tear. This is the superior labrum, anterior to posterior. So what we have the patient do is do like an empty arm test, come across the body, horizontal adduction, and you're gonna resist against my motion. That's pretty painful. I mean, okay. Usually there's a lot of false positives, but that's a good test for slap tear.
Were you just holding here and pushing on the arm, or?
I was just stabilizing the shoulder, have him come horizontal adduction. Then he's gonna resist against my motion, or against my pressure.
Pushing down.
I'm pushing down. Yep. Thank you.
So these are the two tests for slap tears.
What was this one called where you stabilize? Does that have a name?
That was the load and shift test.
Hawkins kind of uses that
Oh, yeah.
thing for it.
Yeah, and then now we're getting assessed for impingement. This is a really overuse injury. Tennis players, baseball players usually get it. There's one where you do Hawkins-Kennedy. So you have them.
Stand up.
You stand up. So you have the patient at 90 degrees of flexion. Then you're gonna bend the elbow at 90 degrees. What you're gonna do is you can push an upward translation or upward force at the elbow joint, and then you're gonna push a downward force with the wrist. Okay. Come up. And with this one, you're trying to elicit pain along the acromion. Yeah. Underneath the acromion.
Subacromial space. This one, if you think about, you're taking the head of the humerus and basically jamming it into the subacromial space. And if there's inflammation or inflamed bursa, a tendon issue or something like that, that's already made smaller to begin with, and then you're pushing the humeral head into that area, making it even smaller. So that's where the pain is getting elicited from.
Yeah. Another one is the Nears impingement. Now just remember this one near to the ear. That's what's always my lap. So you have them pronate, and you can passively put them to flexion as much as you can while stabilizing the shoulder. Same principles, you just want to elicit pain, whether they have internal impingement. Thank you. Good. The drop arm test. This was a little silly, but we also taught this. So you have the patient come up, and then you're just gonna let go, and you're just gonna see if their arms actually drop. Yeah, there you go. Yeah. And that's just indicative of rotator cuff weakness here. some other major ones. I think it's shorter ones. Now we can assess the biceps tendon. There's really two main ones: is speeds and Jurgensen's. So speeds, you're gonna have them flex. You're gonna palpate the bicipital groove. Okay, palpate the bicipital groove while you do this. Then you have them resist your downward force resistance. Okay. It's usually indicative of pain. It's usually indicative of biceps tendonitis. Another one is Jurgensen's. So you can have them either pronate or wrist, or flex wrist. And what you're gonna tell them to do is external rotate the shoulder and supination of the wrist or the forearm. And what you're gonna do is same thing. You're gonna palpate the bicipital groove, and you're gonna resist against that motion. So go ahead, external rotate and supination. Good. There you go. Okay, there you go. Good. So that's speeds and Jurgensen's. Those are really good tests for biceps tendonitis. Let's see. We do some tennis ones. Yeah. Elbow test. Okay. This one's a pretty good one. So if you think about this is what tennis. This works with tennis players. Is what's happening is causing epicondylitis, which is where the extensor carpi radialis brevis is pulling from the area, the lateral epicondyle. So what you want to do is elicit pain. Same mechanics that tennis players use. So you can have them pronate or supinate. You can have them external rotate and extension and radial deviation of the wrist. Okay. So 3 motions. So you can radial deviate, extend, and external rotate. Okay. Radial deviation, extension of the wrist, and come out this way. Okay. So just relax.
Oh.
So you do all 3 of those and like
Then
ones?
you're gonna resist against that motion.
Oh, okay.
Okay, so you can palpate along the lateral epicondyle. So go ahead, resist against it.
Think of the same motion as like you can do backhand.
Good. And with this one, usually you can just help players by asking them to use like a strap.
Choke pass strap that
Maserati was talking about. And what you're doing is you're just moving the insertion point, or the attachment point where the muscle attaches to the bone. Collagen?
I strongly call it the lateral epicondyle.
Or tennis elbow test. Another neat one is if you resist, have them sit down. Or if not, you put your arm. Oh. It's outside of it. That's really cool. And then if you have them resist against your 3rd digit, so resist against this one, you can see his extensor carpi radialis muscle, the common extensor tendon, moving forward. So go ahead. You see that?
What is it?
Right here. Resistive elbow test. So you just have them come up, resist against the 3rd digit, and you see that muscle working. Right there, you also palpate the lateral epicondyle. Some other ones that we learned were the Phalen's test. That's for carpal tunnel syndrome. So you come here. You have them hold that position, and if you elicit pain, then that's indicative of carpal tunnel compression of the median nerve. So that's the Phalen's, and then you also have the reverse Phalen. Usually we should do both. And then another one's, I like the name, it's Finkelstein. It's the Corvin syndrome. That's tenosynovitis of the sheath. It's usually your abductor pollicis longus and your extensor pollicis brevis, I believe. Yeah. So you have them put the thumb inside the fingers. Then you have them do kind of like an ulnar deviation of the wrist. That should elicit pain along the synovial sheath. Yeah, I mean it hurts everyone, but if you're really inflamed and in pain, it'll come up. That's the overuse, yeah.
Injury.
Usually, if anything is inflamed, it's caused from overuse. Just repeated motion.
A lot of people
stress.
things like racket sports, things where you're holding onto a stick like lacrosse or stuff like that, where you're really holding grip stuff.
What's that one called again?
Finkelstein.
Oh.
Yeah. Or Finkelstein. Finkel, yeah.
Yeah. Are you saying Finkel or Finkel?
Finkel.
Finkel.
Now we do the fecal check. Oh, the same thing that Mike was showing with the knee valgus and varus test. You also do the ligaments of your fingers, of your digits. So you also have your ligaments, your collateral ligaments to the side. It's pretty neat. You can actually do the valgus test with the fingers.
Yeah. So if someone dislocates their finger or whatnot, usually just opens wide up like.
Yeah. Then another one, gamekeeper's thumb. Usually you see it with, I guess they named it after soccer goalies because they're like land on their hands and rip the UCL on a collateral ligament with the thumb. And this one, still get in a good position. It's kind of similar to the valgus varus test. What we're gonna do is stabilize the thumb. You're gonna apply force to elicit pain, see if there's any laxity along the joint, the ligament.
So you're putting force where your thumbs are?
Yeah. So I'm stabilizing this one. I'm just using my thumbs to apply it.
And that's on the MCP joint, right?
So just trying to look for the integrity of the UCL. Yep. And I think that's the main shorter ones, upper extremity. Adsons and Allens.
Yeah, that's a ruse.
Yeah, ruse. This is for thoracic outlet syndrome. So say if there's compression of the subclavian artery, you're just gonna grab the radial pulse or radial artery. And then Adsons is where you have them look away.
Adson.
Yeah.
Look towards.
Towards.
Adson at the head.
Yeah.
So
Adsons. So and then you should feel a diminished pulse.
Just doing that?
It's thoracic outlet syndrome.
Basically, when you're doing this, you're compressing the neurovascular bundle that goes into the arm, decreasing that, whether through the scalenes, a cervical rib. So if someone has an extra rib there, basically a congenital thing, you can compress it when you turn your head.
Towards. Oh yeah. Then Allen's is the one where you have L for like Allen, so you kind of there's an L in Allen. But yeah. So you kind of make it look like an L with the elbow. You can do it 90 and 90. Same thing. You're gonna palpate the radial artery. But this time you have them look away. That should also diminish the pulse that you feel. Then ruse. It's pretty silly.
Anyone uses, but
I guess it's on our sheet too. But you just have them come up, have them trap their hands.
basically just
They can't do it for 3 minutes.
You're doing it 3 minutes.
3 minutes. I don't know who invented that. I don't know why they did 3 minutes,
Yeah,
but just keep on doing it. If they can't do it,
I
then
think you're looking for paresthesia and decreased
Perfusion?
yeah,
like decreased blood flow.
because they can't hold it.
Yeah, it's like 3 minutes is a long time.
And that's Sperlings.
Brilliance and traction.
Yeah. Yeah.
Okay.
So do you want us to do
It's the 5-eye test.
Thoracic outlet.
Huh? I assume only one side would be numb
if
or
you're looking-
tingly
so
or.
all these you're gonna do
Bilateral,
bilateral, looking comparatively. What normal could be. Thoracic outlet. So thoracic outlet.
Where did you get all those papers you're looking at? Are they the ones on like?
You can have tingling or numbness in one arm or one arm. You can have basically their hands are always cold because they're not getting blood.
Yeah, it's been on and off.
Swelling.
I don't think I've fucking. Did we hit all of them?
Well, you have to rule out.
Okay, yeah. I think so.
It's usually for scalens are really tight, causing it to compress because the neurovascular bundle goes through. Things in the middle and the anterior scale.
Alright, and for cervical, you have brachial plexus compression, or usually people just call it stingers, burners. You have the patient lateral flex. You just put an axial load downward force into the patient's spine. And that's going to cause either nerve radiculopathy, like nerve pain, and we also do this bilaterally this way. Push, also pressing down axial load right at the crown of the head. Or people call that Sperling's test. And then you have the distraction one. It's this way. What you're gonna do is just grab the occiput and the joint, the jaw, and you're just gonna lift off. You lift the skull. And that should reduce. Oh, sorry. Just pop your jaw. You're gonna lift up the head, and you're gonna try to cause a nerve reducement. You're gonna relieve that compression that's going on with the cervical spine.
What's that called?
Distraction. Cervical distraction.
That one you can also do laying down too. If you need to get better leverage, if you're not tall enough. You can lay down, and just basically pull this way instead of this way.
So if that arm comes in on the floor.
Yes, you could do that too.
Now, when would you do this reduction?
But this is like just it's not a reduction. Like you're not trying to like
Fix it, yeah.
You're not trying to fix it. It's to actually reduce the symptoms. So like say you're having nerve pain, like burning, tingling into your arm, and to see if you'll do that test. If it goes away, then you could tell that it's probably a compression type issue, either when your vertebrae are compressing on the spine or the nerves, something like that that's causing the
Do they
pain.
see an instant, oh wow, that's better, or do you have to kind of hold it for 3 seconds and then like, oh.
To be honest, I've actually never used this one.
Never.
I've used Sperling's.
Yeah, Sperling's, and also like there's another one, the brachial traction test for.
We tried it.
Basically, do the same thing as kind of like Sperling's, but you're not pushing down. You're just holding the shoulder here and just pushing to the side, creating that traction. So like a stinger mechanism is you're going this, like say football, you're going this way. Someone hits you here, the shoulder, so your shoulder goes down, your head goes this way. You're creating that traction of the brachial plexus. That's where that stinger mechanism is, or pain comes from. So you're basically recreating that, trying to create traction on it, which will elicit symptoms. But yeah, I've never used the distraction test.
Thank you, sir. Thanks for that.